Today, I want to talk with you about a man with severe back pain. A 55-year-old male was brought to the ER complaining of severe back pain, which started today about 6 hours ago. He states that the pain started in the upper abdomen as a steady, boring pain radiating to the back. He reports nausea with several episodes of vomiting. He has had similar pain 1 year ago, for which he was admitted to the hospital for 1 week. He is a weekend drinker for the past 10 years. He has no fever, no chest pain, no cough, no diarrhea, and no numbness or weakness in the legs. The patient states that in order to get some relief, he bends forward with his knees drawn up to his chest. The physical exam. On physical exam, the vitals were 100, the blood pressure was 100/55, the heart rate was 120, the respiratory rate was 22, the temperature was 100.8 degrees Fahrenheit, the O2 saturation was 97, and his finger stick was 110. The abdomen is soft, bowel sounds present, with significant tenderness in the epigastrium. The rest of the physical exam was benign. The labs indicate a WBC of 18,000, a lipase of 600, the glucose of 280. The rest of the labs were within normal range. What is the differential diagnosis for this patient? Well, we should consider dissecting aneurysm, pancreatitis, peptic ulcer disease, spinal abscess, mesenteric ischemia, small bowel obstruction, small bowel perforation, and musculoskeletal back pain. What do we have so far? So let's review. Number one, we have a 55-year-old male. Next, we have epigastric pain with significant tenderness on palpation. Next, we also have this gentleman having severe back pain. Then he reports nausea. We know that he's a weekend drinker. And he reports that he pulls his knees to his chest to get relief. He also had previous admission for similar pain, and the vitals revealed that he is hypotensive with compensatory tachycardia. This patient has pancreatitis. The diagnosis is made by the patient's presentation and abnormal labs, namely elevated lipase. So, what is pancreatitis? It is a non-bacterial inflammation of the pancreas due to digestion of the pancreas by its own enzymes. As a result of the inflammation, bradykinin is released, causing pulmonary edema and pleural effusion, which are associated with acute pancreatitis. And these pulmonary presentation are normally seen on the left side of the lungs. Due to autodigestion, the pancreas might sustain damage, leading to heavy bleeding, which can manifest as ecchymosis in the flank. This is known as gray Turner sign. There may also be periumbilical ecchymosis, which is known as the Collins sign. Patients may also become hypotensive and tachycardic. Abdominal CAT scan is not necessary to make the diagnosis of acute pancreatitis. So let's talk about the Ransom Criteria. This is a system that is used to predict morbidity and mortality and usually becomes applicable 48 hours after admission. On admission, if the patient is over 55, if the WBC is over 16,000, if the LDH is greater than 350, if the SGOT is greater than 250, and if the glucose is greater than 200, then this becomes a concerning sign, and it raises the concern as to the prognosis of the patient. However, within 48 hours of admission, if the hematocrit decreased by 10%, if the BUN increases by 5 milligram per DL, if the PaO2 decreases below 60, if the calcium decreases below 8 milligram per DL, if the base deficit increases greater than 4 milliequivalent per liter, and if there's fluid deficit that is greater than 6 liter, then there is reason to believe that there might be a bad outcome or poor prognosis. The presence of 3 or more are associated with high mortality. The etiology of pancreatitis. The most common cause are alcohol and gallstones. Other causes include hypertriglyceridemia, hypercalcemia, trauma, and scorpion bite. The complications of pancreatitis include death, cardiovascular collapse from hypovolemia, pulmonary complications, electrolyte imbalance, diabetes, and DIC. This patient had an episode of pancreatitis in the past, for which he was admitted and treated. Here are a couple questions. How would chronic pancreatitis appear on abdominal X-ray? Well, the pancreas would demonstrate calcifications. Next question. What is a sentinel loop of bowel? Well, it is a dilated loop of bowel in the region of the pancreas. How is acute pancreatitis treated? Well, we start with the ERCP if gallstone is suspected. Then the patient would be put on IV fluids. Also, analgesics should be given to the patient. Very importantly, morphine should be avoided because it constricts the sphincter of OD. Then the patient should have his bowel rest. Then antibiotics are not indicated in acute pancreatitis. Very important to remember. Antibiotics are not indicated in acute pancreatitis. The patient was admitted to the hospital and discharged after 4 days. Well, thanks for watching, and I hope this short presentation provided a framework on which you can build a deeper understanding of pancreatitis. Good night. I wish you well.